Hello everyone. Welcome to the fourth lecture in this series of gastrointestinal pathology. In the prior three lectures, we have discussed the pathology of the esophagus, the stomach, and the non-neoplastic disorders of the intestines. Now, in this fourth lecture, we are going to talk about the polyps and tumors that affect the colon. They can also occur at other sites in the gastrointestinal tract. At the end of this lecture, you will be able to identify the common polyps that occur in the colon, and you will be able to distinguish the different tumors that occur in the colon. You will be able to know their characteristics, histologic and immunophenotypic features, their prognosis, and their origin. So this is the outline that we will follow. First, we will start talking about the polyps, and then we will move into the tumors, where we will discuss adenocarcinomas, neuroendocrine neoplasms, gastrointestinal stromal tumors, and finally lymphomas. Broadly speaking, the term polyp refers to any form of lesion that projects above the surrounding colonic mucosa. Polyps can occur anywhere in the gastrointestinal tract. They can occur in the esophagus, stomach, and small intestine, but they are most common in the colon and rectum. Polyps can be sessile, which means that they do not have a stalk, or they can be pedunculated. Pedunculated polyps are polyps with stalks. The vast majority of colorectal polyps are adenomatous, serrated, which includes hyperplastic polyps and sessile serrated lesions, inflammatory polyps, and hamartomatous polyps. So we will start with adenomatous polyps or adenomas. They are the precursors to the majority of colorectal adenocarcinomas. However, the majority of adenomas do not progress to become adenocarcinomas, but they are the precursors to the majority of carcinomas. They range from small, often pedunculated polyps to large sessile lesions. And by definition, they are characterized by having dysplasia. Dysplasia is characterized by nuclear hyperchromasia, nuclear elongation, and nuclear stratification. So they should have at least low-grade dysplasia. Adenomas are classified into tubular adenomas, tubulovillous adenomas, and villous adenomas. Tubular adenomas consist predominantly of tubular glands. Villous adenomas consist predominantly of villi, and tubulovillous adenomas have a mixture of tubular glands and villous architecture. And the best predictor for the presence of malignancy within an adenoma is the size of the polyp. So the larger the polyp is, the higher the likelihood that it may be harboring a carcinoma. Villous adenomas and adenomas with high-grade dysplasia have an increased risk of developing adenocarcinoma also. Dysplasia can be either low-grade or high-grade. When it is high-grade, the risk for adenocarcinoma is higher. Here in the picture on the left, we can see three small polyps. And in the picture on the right, we can see a pedunculated polyp with a stalk. Just by looking at the polyps grossly, you cannot know the nature of the polyp. You have to examine it under the microscope in order to determine the nature of the polyp. This is an example of a tubular adenoma. So here is the polyp, and it consists predominantly of tubular glands. And if we compare this polyp with the normal colonic mucosa present here in the upper right of the picture, we can see that the polyp has an overall darker appearance. And this is because it has low-grade dysplasia, which means there is nuclear elongation, stratification, and hyperchromasia. The majority of adenomatous polyps have low-grade dysplasia. If a polyp develops high-grade dysplasia, then this polyp should be completely excised because it has higher risk of progressing into invasive carcinoma. These are pictures of villus adenomas. In the picture on the left, we can see the gross appearance of a villus adenoma. These lesions are usually characteristically large. They have an arborescent architecture where we can see the cauliflower-like projections. In the picture on the right, we can see the microscopic image of the villus adenoma where there is villus architecture. We can see the many villi as opposed to the tubular glands that we saw in tubular adenoma. So here we see villus architecture, and in addition we have low-grade dysplasia. Hyperplastic polyps can be found anywhere in the colon, but are most commonly seen in the left colon. They are usually small polyps, less than 5 mm in size, and they are characterized by having a serrated architecture. The serration in hyperplastic polyp is seen in the surface epithelium and the superficial part of the crypts. And hyperplastic polyps, they do not have malignant potential, and therefore they do not affect colonoscopic surveillance intervals. The significance of recognizing hyperplastic polyps is that they must be distinguished from sessile serrated lesions, which also have serrations, so they have some histologic similarities. However, the sessile serrated lesions have some malignant potential. We will discuss the sessile serrated lesions in the coming few slides. These are pictures of hyperplastic polyp. We can see that there are serrations affecting the epithelium. So there is branching of the crypts, and we can notice that there is no dysplasia. Now we come to sessile serrated lesions. They are also referred to as sessile serrated adenoma/polyp. They have a predilection for the right colon, for the proximal colon. And if left within the patient and if they are large, they have an increased risk of developing into adenocarcinoma. They are characterized microscopically by the presence of serrations. So there is histologic overlap with hyperplastic polyps, which also have serrations. But there are some differences between the two. In sessile serrated lesions, the serrations are present throughout the length of the gland, including the crypt base, whereas in hyperplastic polyps, the serrations usually are limited to the surface of the crypt, the upper half of the crypt. In sessile serrated lesions, there is usually crypt dilation and lateral crypt growth, which means that the crypt at its base, it branches horizontally to the muscularis mucosa, creating an inverted T or L shape. We will see a picture of it in the next slide. Sessile serrated lesions also, as we said, are predominantly located in the right colon as opposed to the hyperplastic polyps, which are usually present in the left colon. These are two pictures of sessile serrated lesions. As we can see that there are serrations throughout the length of the crypt, and at the base of the crypt there is dilation and there is branching parallel to the muscularis mucosa, creating an inverted T or L shape. And here we can see the branching, so there is lateral crypt growth. And by definition, sessile serrated lesions, as their name implies, they are sessile polyps, so they are not pedunculated. Inflammatory polyps usually occur in patients with inflammatory bowel disease, such as ulcerative colitis and Crohn's disease. Patients with inflammatory bowel disease usually have inflamed colonic mucosa with ulceration. And in the intervening non-inflamed mucosa, these areas can become inflamed and can undergo regenerative hyperplasia, creating a polypoid appearance. So there will be a polypoid mucosa that is inflamed and it projects above the surrounding mucosa, which is usually ulcerated. So it's like a polypoid mucosa that is inflamed. This is a picture of an inflammatory polyp. There is polypoid appearance of the colonic mucosa, and there is dense inflammation within the lamina propria. Now we come to a hamartomatous polyp. Hamartomas are overgrowth of cells and tissues native to the anatomic location in which they occur, which means, in other words, hamartomas are growth of colonic tissue with distorted architecture, and they can incorporate both stromal and epithelial components. Hamartomas are most often solitary, but they can be multiple, and when they are solitary, they are usually due to sporadic causes. When they are multiple, you should make sure that the patient does not have a hamartomatous polyposis syndrome, because some of these hamartomatous polyposis syndromes are associated with increased cancer risk, either within the polyp or at other intestinal site or at extraintestinal site. So, a subset of hamartomatous polyps, when they are part of a polyposis syndrome, they are considered to be pre-malignant neoplastic lesions. It is also important to recognize these polyposis syndromes because of the associated extraintestinal manifestations and the possibility that other family members are affected. Examples of hamartomatous polyposis syndromes include juvenile polyposis syndrome and Peutz-Jeghers syndrome. Isolated hamartomatous polyps, they are sporadic and they do not have malignant potential. A juvenile polyp is a hamartomatous polyp. The majority of juvenile polyps occur in children. However, they can present at an older age. When they present at an older age, sometimes they are referred to as retention polyp. Sporadic juvenile polyps are solitary polyps, and they do not have increased risk for malignancy. And isolated sporadic juvenile polyps, so as we said, they do not have malignant potential, therefore they do not require further follow-up. It is a non-neoplastic polyp. Juvenile polyposis syndrome is an example of a hamartomatous polyposis syndrome. It is an autosomal dominant syndrome, and it usually occurs in children, where the mean age at presentation is less than 5 years old, and the patient has 3 to hundreds of juvenile polyps. And patients are at increased risk of developing colorectal carcinoma. Peutz-Jeghers syndrome is another hamartomatous polyposis syndrome. It is also an autosomal dominant syndrome where patients have germline mutations in STK11 gene. And in Peutz-Jeghers syndrome, multiple hamartomatous polyps occur in the gastrointestinal tract. These Peutz-Jeghers polyps, they can occur in the small intestine, the stomach, the colon, and the patients usually are children. The median age is around 11 years old, and also patients have mucocutaneous pigmentation. They have dark blue to brown macules on the lips, nostrils, buccal mucosa, palmar surfaces of the hands, genitalia, perianal region. And it's important to recognize the syndrome because patients are at markedly increased risk of several malignancies such as breast, colon, pancreas, stomach, and ovary. So the malignancies can occur in the GI tract and outside the GI tract. Now we will discuss the neoplasms that occur in the colon. and we will start with colonic adenocarcinomas. Colorectal adenocarcinoma is the most common malignancy of the gastrointestinal tract. It is responsible for approximately 10% of all cancer-related death worldwide and is the second most common cause of cancer-related death in the United States after lung cancer. The incidence peaks at 60 to 70 years of age, and established risk factors include environmental, such as a sedentary lifestyle, dietary habits, such as consumption of processed and red meat, consumption of alcohol, and excess body fat. On the other hand, consumption of dietary fiber and dairy products and increased levels of physical activity decrease the risk of colorectal cancer, as does the prolonged use of NSAIDs. Genetic factors are also implicated in the pathogenesis of colorectal carcinoma. They are divided into three groups by location: right-sided or proximal colon carcinomas. They are carcinomas that occur in the cecum, ascending colon, or transverse colon. Left-sided colon carcinomas, they occur anywhere from the splenic flexure to the sigmoid colon, and rectal carcinomas. The majority of colorectal carcinomas are left-sided or rectal. Colorectal adenocarcinomas have a variety of macroscopic or gross appearances. They can be a polypoid or exophytic mass bulging into the lumen, or you can have a mass with central ulceration and rolled edges, and it infiltrates deeply within the wall. Carcinomas are also graded. They can be low grade, which means that the tumor is well to moderately differentiated and consists of infiltrative glands, or the tumor can be high grade, which means that it is poorly differentiated and consists predominantly of solid sheets and single cells. In this slide, we can see the different gross appearances of colorectal adenocarcinoma. Here in the picture on the left, we can see a polypoid pattern of growth of a colorectal carcinoma. In the picture on the middle, we can also see a polypoid mass with central ulceration. And in the picture on the right, we can see an ulcerated tumor that is deeply penetrating. In this slide on the left, we can see another gross picture of a colorectal adenocarcinoma. We can see that the tumor is forming a big polypoid mass with central ulceration and necrosis. In the picture on the right is a microscopic image of a colon carcinoma, adenocarcinoma, and we can see that the tumor consists of infiltrative glands that are infiltrating throughout the colonic wall. Mucinous adenocarcinoma is the most common subtype of colorectal carcinoma, and it is characterized by the presence of pools of extracellular mucin that contain tumor cells. This tumor stage is determined by the T and M classification. The T is determined by the extent of depth of invasion of the tumor through the colonic wall. For example, if the tumor is limited to the submucosa, it is at an earlier stage. If it has invaded into the fat, that's a higher T. The N is determined by the presence or absence of lymph node metastasis, and the M is determined by the presence or absence of distant metastasis. Colorectal carcinomas can metastasize to various sites in the body, such as the lungs and bones, but the liver is the most common site of distant metastasis. This is an example of a mucinous adenocarcinoma, which is a variant of colorectal adenocarcinoma, and it consists predominantly of pools of extracellular mucin, and the epithelial tumor cells are floating within these pools. In the picture on the left, we see a lymph node, and this lymph node is involved by metastatic adenocarcinoma, where we can see these malignant glands present within the lymph node, so that carcinoma has metastasized to the lymph node. In the picture on the right, we can see a section from a liver. So here is the normal liver consistency. We can see it's brown. And here we can see a big mass, a yellow mass, another big mass, and multiple smaller masses. So all of these masses are metastatic deposits. So colorectal adenocarcinoma has metastasized to the liver and formed multiple masses, large and small. Now we will talk about neuroendocrine neoplasms of the gastrointestinal tract. Neuroendocrine neoplasms are tumors of neuroendocrine cells. Neuroendocrine cells are cells that have features of both endocrine cells and neural cells. These tumors can arise anywhere in the gastrointestinal tract. They can occur in the small intestine, the colon, the appendix, the stomach, and the pancreas. They can also occur outside the gastrointestinal tract, such as in the lungs. Neuroendocrine tumors are tumors with malignant potential. Neuroendocrine tumors can be classified into functioning tumors and clinically non-functioning tumors. Functioning neuroendocrine tumors are tumors that produce hormones, and this abnormal production of hormones results in clinical symptoms. Clinically non-functioning neuroendocrine tumors can also produce hormones, which can be detected in the serum, but the hormones do not result in symptoms. The pancreas gives rise to the greatest variety of functioning neuroendocrine tumors. An example of a functioning neuroendocrine tumor is a gastrinoma, which produces gastrin, and it results in Zollinger-Ellison syndrome. These tumors usually occur in the duodenum or pancreas. Functioning neuroendocrine tumors can also cause carcinoid syndrome, and these tumors usually arise in the ileum. Carcinoid syndrome occurs in less than 10% of patients with neuroendocrine tumors, and it is caused by the release of vasoactive substances such as serotonin, which are secreted by the tumor into the systemic circulation. The symptoms include cutaneous flushing, sweating, bronchospasm, colicky abdominal pain, diarrhea, and right-sided cardiac valvular fibrosis. Carcinoid syndrome is strongly associated with the presence of metastatic neuroendocrine tumor. It's strongly associated with metastasis when it occurs. Why is that? This is because when neuroendocrine neoplasms are confined to the intestine, the vasoactive substances that are released, such as serotonin, they are metabolized to inactive forms by the liver, by the first pass metabolism. So the carcinoid syndrome does not occur. However, when there is metastasis, these vasoactive substances, they bypass the portal circulation and the liver, and they cause symptoms. So carcinoid syndrome results. Neuroendocrine neoplasms can be either neuroendocrine tumors, which are well-differentiated tumors, or they can be neuroendocrine carcinomas, which are poorly differentiated carcinomas. And the degree of differentiation refers to the extent to which the neoplastic cells resemble their non-neoplastic counterparts. Neuroendocrine neoplasms are also graded, and grade refers to the inherent biologic aggressiveness of the tumor. Grading is based on two main things: the number of mitotic figures and the Ki-67 proliferation index. The Ki-67 is an immunohistochemical stain that can be performed on tissue sections to assess proliferative activity. Microscopically, neuroendocrine neoplasms have a variety of architectural patterns. They can be arranged in islands, nests, trabeculae, and sheets. The neuroendocrine cells are uniform cells and have a characteristic chromatin that is coarsely clumped, also referred to as the salt and pepper chromatin pattern. By immunohistochemistry, neuroendocrine tumors are positive for synaptophysin and chromogranin, which are immunohistochemical stains that indicate neuroendocrine differentiation. In this slide, we can see cross pictures of neuroendocrine tumors. In the picture on the left, we can see a neuroendocrine tumor occurring in the ileum. It is forming a polypoid mass. In the picture on the right is a picture of an appendix, and the appendix is a common site of neuroendocrine tumors. And when neuroendocrine tumors occur in the appendix, usually they occur in the tip of the appendix. They are well circumscribed tumors and have a yellow-tan color. In this slide, we can see microscopic images of well-differentiated neuroendocrine tumors. In the picture on the left is a lower power view where we can appreciate the architecture of the tumor, where we can see that the tumor is arranged in anastomosing trabeculae. In the picture on the right is a higher power view where we can see that the tumor cells are monotonous and uniform, and they have a characteristic chromatin pattern that is coarsely clumped, also referred to as salt and pepper chromatin pattern. In the picture on the left, it is an immunohistochemical stain for chromogranin, where we can see that the neuroendocrine tumor is positive for chromogranin. The cells are staining brown, which means that they are neuroendocrine in origin. In the picture on the right is an electron microscopic image which shows a well-differentiated tumor containing numerous neurosecretory granules, which are characteristically seen in well-differentiated neuroendocrine tumors. Now we move on to gastrointestinal stromal tumors or GISTs. Gastrointestinal stromal tumors are mesenchymal neoplasms. Mesenchymal as opposed to epithelial neoplasms such as carcinomas and lymphoid neoplasms or lymphomas. And GISTs originate from the interstitial cells of Cajal. Interstitial cells of Cajal are present throughout the wall of the gastrointestinal tract, and they function to coordinate the peristalsis by generating and propagating electrical waves of depolarization. These interstitial cells are mesenchymal cells, and they are located within the muscle layers of the alimentary tract, and they mediate communication between the autonomic nervous system and the smooth muscle. That is why they are also called the pacemaker cells of the GI tract. KIT or CD117 is a receptor tyrosine kinase, and this receptor tyrosine kinase plays an important role in the development and maintenance of the interstitial cells of Cajal. This slide illustrates the normal distribution of the interstitial cells of Cajal, which are located in the myenteric plexus and adjacent muscularis propria. The interstitial cells of Cajal are highlighted by the CD117 immunohistochemical stain, which highlights them as brown. So we can see their distribution over here within the myenteric plexus and within the adjacent muscularis propria. 75% of GISTs have activating mutations in the receptor tyrosine kinase KIT. Another 10% have activating mutations in PDGFRA or platelet-derived growth factor receptor alpha, which is also a receptor tyrosine kinase. Mutations of KIT and PDGFRA are mutually exclusive, which means that the tumor has either constitutive activation of KIT or PDGFRA. Imatinib is a selective tyrosine kinase inhibitor that targets KIT and PDGFRA and is widely used in treatment of cysts. This slide illustrates the pathogenesis behind cysts and the mechanism of action of imatinib. Normally, the binding of KIT ligand to the receptor tyrosine kinase KIT leads to phosphorylation of signal transduction proteins that promote cell proliferation and inhibit apoptosis. In GIST, there is activating mutation of the receptor tyrosine kinase KIT, and this will lead to constitutive activation of this pathway even without the presence of KIT ligand, leading to cell proliferation. In imatinib, what happens that imatinib blocks the binding at the site of ATP, so it blocks ATP from binding to the receptor, thereby stopping the signaling pathway. Gastrointestinal stromal tumors can occur anywhere in the GI tract. The most common site is the stomach, followed by the small intestine, and much less commonly they occur in the colon. The behavior of GISTs ranges from benign to malignant, and risk stratification is preferred to anatomical staging. And the best documented prognostic parameters in GISTs are anatomical site. For example, gastric GISTs are less aggressive usually than those arising in the small intestine. Mitotic activity, the higher the mitotic activity, which means the higher the proliferative activity of the tumor, the worse the prognosis. And tumor size, the larger the tumor, the worse the prognosis. GISTs can metastasize, and when they metastasize, they usually go to the liver and to the serosa within the abdominal cavity. GISTs can have a variety of morphologic appearances. They can be either spindle cell, which means the cells are thin and elongated, or the cells can be epithelioid, which means they are plumper cells, polygonal in shape, and they have more cytoplasm, thus resembling epithelial cells, hence the name epithelioid. But they are not epithelial cells. As we said, they are mesenchymal cells. Or the tumor can consist of a mixture of spindle cells and epithelioid cells. By immunohistochemistry, those tumors are positive for CD117 or KIT and DOG1. GISTs usually can be either submucosal or intramural masses, so they arise beneath the mucosa, unlike carcinomas which arise from the overlying epithelium. So they start in the mucosa and then they extend deeply. In GISTs, they arise beneath the mucosa, so they can be submucosal or intramural tumors. Here in the picture on the left, we can see here we have the overlying mucosa that is intact, and beneath it we have the tumor, which is well circumscribed and small. In this picture on the right, we can see another example of a cyst where we can see it's a large tumor and it is hemorrhagic. So cysts can have a variety of gross appearances. This slide illustrates the variety of microscopic appearances of cysts. In the picture on the left, we can see here that the cyst is composed of spindle cells. Spindle cells are thin, elongated cells. In the picture on the right, we can see that the tumor cells are epithelioid. They are polygonal and have plump cytoplasm resembling epithelial cells. So as we said, cysts are positive for CD117 immunohistochemical stain, And in this slide, we can see that the tumor cells are strongly positive for CD117 and they are staining brown. Finally, we will now briefly discuss lymphomas. Lymphomas in the gastrointestinal tract can be either primary to the gastrointestinal tract or it can involve the gastrointestinal tract as part of systemic involvement. Various types of lymphomas occur in the GI tract, and these usually are mostly non-Hodgkin B-cell lymphomas. T-cell lymphomas are rare in the GI tract. They can occur, but they are very rare. And the most common type of lymphoma is the extranodal marginal zone lymphoma or MALT lymphoma. Diffuse large B-cell lymphoma is also another common lymphoma. Other less common lymphomas include follicular lymphomas, mantle cell lymphoma, and Burkitt lymphoma. The stomach is the most common site of the gastrointestinal tract that can harbor a lymphoma, as we discussed in the lecture in the gastric pathology. And the GI tract is the most common site of extranodal lymphoma. This is a microscopic image that shows a diffuse large B-cell lymphoma involving the colon. We can see that there is a diffuse population of large atypical lymphoid cells that are expanding the lamina propria. We now reach the conclusion of our lecture. We discussed in the first part of it the different polyps that occur, and these include adenomatous polyps, serrated polyps, which can be hyperplastic, or sessile serrated lesions. We also talked about inflammatory and hamartomatous polyps. And then we moved to the second part where we discussed the different neoplasms, and these include colorectal adenocarcinomas, which are the most common malignant tumors in the GI tract. And then we talked about neuroendocrine neoplasms, which are tumors that have both endocrine and neural features. They are positive for synaptophysin and chromogranin, and clinically they can be functioning or non-functioning tumors, and they can occur at various sites within the GI tract. And then we talked about gastrointestinal stromal tumors or GISTs, and these are mesenchymal tumors that arise from the interstitial cells of Cajal, and they can be submucosal or intramural tumors. They are positive for CD117 by immunohistochemistry, and they are characterized by activating mutations in KIT in the majority of cases. Less commonly, they have activating mutations in PDGFRA, and imatinib is widely used in treatment. And finally, we talked about lymphomas. And in the next lecture, we will talk about the pathogenesis and molecular biology of colorectal adenocarcinomas.